Thank you to everyone for joining us this evening for this webinar. I'm really excited to bring this to you. My name is Dr. Bridget Sutton, as Laura said, and I'm the Clinic Director at Scan IMED in Queensland. And I'm going to be talking to you this evening about imaging pathways for endometriosis, one of my favourite topics. My declaration of interest is literally that I have nothing of note to declare. And it's really timely that we are giving this webinar in March, because March, of course, as you all know, is Endometriosis Awareness Month. And we will be hopefully doing some projects later on, if not this month, then later on in the year with our colleagues with Endometriosis Australia. That's something that we can look forward to perhaps a little later in the year. But this webinar is really only one component of a larger endometriosis awareness 2026 initiative that IMED has launched this month. Alongside this webinar, we have published new content for both clinicians and patients to support the updated RANSCOG guidance, emphasising imaging in the diagnostic pathway on the IMED website. There are some really excellent resources on the website, and I really encourage everyone to take a look if they can. There's also a link to RANSCOG's Raising Awareness Tool for Endometriosis, which is a quick online questionnaire helping patients and healthcare professionals assess symptoms commonly associated with endometriosis to support earlier discussion with the doctor about diagnosis and management. So there's a lot of new stuff on the website. Really encourage you to take a look if you get a second. So let's talk about these new guidelines. The Australian Living Evidence Guideline for Endometriosis is quite a remarkable body of work. This is been years in the making. Many experts have put a lot of time and effort into this organic, incredible body of work. It's a regularly updated resource. It replaces the 2021 Foundation Guideline. The idea is to incorporate the latest research for the Australian context specifically. It grades methodology to assess the certainty of evidence for its recommendations, with appendices that detail the development process and the supporting evidence as well. So it gives clinical guidance covering signs and symptoms, diagnosis using ultrasound and MRI, various management options including hormonal treatments, surgery, pain management, not just analgesics, but neuromodulators, non-pharmacological approaches like physio, mindfulness, medical cannabis, also considerations for fertility and adolescence, which is new and inclusive. There's an emphasis on patient-centered care and shared decision-making, but it addresses inequities also in access and diagnosis for diverse populations, including our First Nations population. So let's go back to basics. Let's talk about endometriosis, the definition for which is tissue similar to the lining of the uterus called the endometrium growing outside of the uterus. Fairly straightforward definition, by no means a straightforward condition. It's first and foremost an inflammatory disorder. We know it's hormone dependent, estrogen dependent, progesterone resistant, and it's commonly associated with a triad of symptoms: pain with periods, pain with sex, and infertility. It affects, we now know, up to 1 in 7 girls, women, and those assigned female at birth, and that's almost 1 million Australians. In 2021, it was calculated to be equates to about nearly $250 million of direct healthcare cost, and a total economic burden of endometriosis was estimated to be between $7.4 and almost $10 billion per year, which is obviously substantial. So common symptoms associated with endometriosis, we know in about 25 to 70% of cases will be severe, painful periods, pain with sex, pain during or after intercourse, infertility, pelvic pain, heavy menstrual bleeding. Oh, sorry, computer just gone a little bit quiet on me. Here we go. Less common symptoms associated with endometriosis in about 10 or 25% of cases will be bowel-related symptoms, constipation, diarrhea, or pain with bowel movement, back pain, urinary symptoms. Things like sleep difficulties, headache, or allergies, and you may have seen definitely in the media or the socials recently, there's been some association with autoimmune disorders and definitely family history. So the guidelines have basically talking about first-line investigations. Until recently, the diagnosis of endometriosis was often delayed by a reliance on surgery. So major guideline revisions such as those from ESHRA and the IDEA group So that's the International Deep Endometriosis Analysis Group, as well as RANZCOG, the Australian Living Evidence Guidelines, now recommend that transvaginal ultrasound is a first-line investigation, primarily transvaginal ultrasound, sorry, is a first-line investigation for people with symptoms suggestive of endometriosis. They also recommend that pelvic MRI should be considered where pelvic ultrasound is not appropriate, and this is new. If transvaginal ultrasound or MRI are not available or appropriate, this is when we should consider transabdominal ultrasound. And if deep endometriosis is suspected on examination or transvaginal ultrasound, again, MRI should be considered. And this is all new. MRI was typically or previously reserved for the pre-surgical patient. So these are all new considerations. Now, of course, the recommendations go on then to say that ultrasound scans and pelvic MRIs should ideally be performed and or interpreted by healthcare professionals with specialist expertise in gynecological imaging, which makes sense. However, as you are probably all aware, we now have the number of patients who are requiring pelvic imaging, ultrasound or MRI, is starting to far outweigh the number of specialist gynae imaging clinics. So the healthcare math is not perfect at this stage, but we will talk about that a little bit later on in the talk. So let's talk about the different subtypes of endometriosis. We have three subtypes that we recognize: superficial endometriosis, which sometimes is referred to as peritoneal endometriosis, and this is one of the most common type. We consider it sits on this peritoneal surface. Ovarian endometriomas, or deep infiltrating endometriosis. And ultrasound in general, historically, we did not do well. We did not perform ultrasound very well for our endometriosis patients in the past. We didn't see endometriosis very well. We didn't know how to look for it. We didn't recognize the findings or the features of endometriosis very well in the past. Until this particular turning point, in 2016, this international consortium put together this quite remarkable resource, this article, which was the systematic approach to sonographic evaluation of the pelvis in women with suspected endometriosis. This is the IDEA group, the International Deep Endometriosis Analysis Group. And this OG article is the resource that we still use, continue to use globally, to perform ultrasound in women with suspected endometriosis, to explain those underlying symptoms, to diagnose it, to map it out, and to describe it. And this was a real turning point for diagnosing endometriosis with ultrasound in women with endometriosis. And there's really, the purpose of this was twofold. First of all, to have a systematic approach to examining the pelvis of those women with suspected endometriosis, to more thoroughly examine it, but also to use defined terms and measurements to describe the appearance of endometriosis so that we're all talking the same language. And it boils down to 4 steps. The first of which is a routine evaluation of the uterus and the adnexa. So looking at the uterus, looking at the ovaries, but we're looking for things like adenomyosis. As we know, there is a strong correlation between women who have endometriosis. A large percentage of them will also have adenomyosis. And we're also looking for the presence or absence of an endometrioma in the ovaries. Step number 2 is to look for what we call sonographic soft markers. So we're looking for site-specific focal tenderness in the adnexa, or in the pelvis in general, and ovarian mobility. So when we nudge around with our probe, do things move around? Are the ovaries, are the adnexa mobile? Is the uterus mobile? So things move around easily. Are they focally tender? Step number 3, the assessment of the status of the pouch of Douglas using real-time ultrasound-based, what we call the sliding sign. You've seen this in the reports before. So when we nudge with our probe, can we get the uterus and the cervix and the rectum to slide past each other? So the gynecologists, you'll see, refer to this as if the rectum is stuck to the back of the uterus, we talk about the pouch of Douglas being obliterated. It's very dramatic. I know, not just stuck, it's obliterated. I know, seems a little dramatic. But basically what we're looking for is to see, is that pouch sliding and moving easily, or is it stuck to each other? Therefore, if it doesn't move, it's a negative sliding sign. If it moves easily, it's a positive sliding sign. That's what we're looking for. And step number 4 is assessment for actual deep endometriosis nodules. So we're looking for nodules in the anterior compartment and the posterior compartment. They're the 4 steps. So let's break it down. So step number 1, this is a picture of a uterus. We're looking for evidence. Not only we're measuring up the uterus, we're looking at the endometrium, we're looking for any obvious pathology in the endometrium, but we're also looking for evidence of adenomyosis, a bit like this. This is a globular uterus. We're looking at the endometrium. The endometrial myometrial interface is completely obscured here in the anterior wall. We've got these tracts, these echogenic buds and tracts that are making their way into the myometrium. We've got myometrial cysts, endometrial cysts, plenty of evidence, ultrasound evidence of adenomyosis in the uterus. Down here we have a very typical appearance of an endometrioma in the right ovary. So a slightly irregular looking cyst, low-level internal echoes. If I applied my Doppler there, I'd see that there's no peripheral vascularity. This is an endometrioma in the ovary. Secondly, we're looking for evaluating for sonographic soft markers. So this is a picture of a uterus, and the ovary is literally stuck to the back of the uterus. So it's medialized, it's pulled out of its lateral position, stuck to the back of the uterus. This is an ovary that doesn't move. Sorry, that's a bit of a sketchy video there. This one here is an ovary that it's still sitting in its lateral position. Maybe there's a little bit of mobility at the lateral edge. The medial edge is completely adherent to the side of the uterus, and this patient was very tender on both cases when we were pushing on those ovaries. So they are focally tender and non-mobile. Assessment of the pouch of Douglas with the sliding sign. You'll notice this uterus has got a real hook on it. So this is anteverted retroflex at the fundus, pulled into retroflexion at the fundus by all of this endometriosis on the back of the uterus. So this is a woman with quite significant posterior compartment disease. This is all endometriosis back here, and the bowel is completely adherent to the back of the uterus. So she has a negative sliding sign, an obliterated pouch of Douglas, very dramatic, obliterated. So it is obliterated to the top of the fundus, and that is a negative sliding sign. And fourthly, we're looking for actual nodules of deep endometriosis. This is a large bowel invasive nodule, which we can see in the second video is situated behind the cervix. So this is a retrocervical bowel invasive nodule in a woman who has deep endometriosis. So that is number 4. The uterosacral ligaments are a very common location for deep infiltrating endometriosis. It's one of the places that we look the hardest for our deep nodules. They're thick bands of connective tissue. They connect the cervix to the sacrum. They support the uterus and other pelvic organs. They're part of the pelvic support system, and they're not always easy to identify when they're normal, be that ultrasound or MRI, because they're thin. When we look at them on ultrasound, they look like this thin white line. You can see they're running along here. So they're a thin, bright, white echogenic line, and they lie deep to the vaginal wall, and the posterior, they insert into the posterior wall of the cervix here at the level of the internal os. So that's what a uterosacral ligament looks like on ultrasound. And when it's abnormal, we're looking for these little nodules here. So this is a little deep endometriosis nodule in the uterosacral ligament on the right. And when we're doing little cine loops here, you can see this faint little thing here is a nodule within the uterosacral ligament. More impressively, this lady here has not only a nodule in the uterosacral ligament, but she has a ginormous nodule eating into her rectum at the back. That's a bowel nodule and a uterosacral ligament nodule. Similarly, this lady has a bowel nodule and a uterosacral ligament nodule here as well. So she's got extensive posterior compartment disease. Superficial endometriosis is something that certainly I was, and I know a lot of my colleagues were quite dismissive about in years gone by. And this is part of this incredible steep learning curve that we have all been part of when it comes to everything to do with endometriosis, but certainly to do with the imaging aspect of endometriosis. So superficial endometriosis, as we mentioned earlier, is the sort of peritoneal, very superficially situated endometriosis. Historically, we used to talk about it being less than 5 millimeters infiltrating the peritoneal lining. That's a histological diagnosis that's not so commonly used now. It's probably the most common variant. We think the true prevalence is unknown, but thought to be found in maybe 80% of women with endometriosis and about 40% of asymptomatic patients. About 29% of women with endometriosis will only have superficial disease. And when we look at it on imaging, these are small echogenic foci or small hypoechoic pockets, cystic spaces that have been identified. And usually they're outlined by a small amount of fluid. So often we will need to have this little bit of the negative contrast effect of a little bit of free fluid within the pelvis to see superficial endometriosis. So in the past, we were ignoring all of these findings because we didn't realize what we were looking at. It's only in the last couple of years that we actually realized that we're seeing superficial endometriosis. And the direct signs are what we're looking for. So these little bits of low signal tissue with fibrotic stroma, little bits of bright foci within cysts, which we think might be bits of hemosiderin, small or large peritoneal pockets with vesicles or small clustered cysts, or filamentous adhesions within the fluid themselves. And we commonly see them within dependent areas of the pelvis, so low in the pelvis, the pouch of Douglas, the vesicouterine space, dependent areas low in the pelvis, again outlined by fluid. They need to be fixed to the peritoneal surface for us to see them with imaging, which is the limitation. The problem is there are going to be lots of false positives. So things that can look similar will be adhesions, the sequelae of pelvic inflammatory disease. Retrograde menstrual clots can look exactly like superficial endometriosis. Rarely things like peritoneal carcinomatosis, imaging artifacts. So it's very difficult to be definitive about superficial endometriosis. We can raise it as a possibility, but it's very hard to be definitive when you see it on imaging. So it's also difficult limiting when to look at peritoneal surfaces higher in the pelvis, and it's very difficult when we don't have fluid. Some of my colleagues, including Matthew Leonardi, who's amazing and has published widely and lectured widely on superficial endometriosis, uses a technique where he actually infuses fluid into the cavity, and then it makes its way through the fallopian tubes, and as a result, he can put some fluid into the pelvis and can outline superficial endometriosis that way. But in lieu of that, you need to have from free fluid in the pelvis to see superficial endometriosis in a lot of cases. So it's a little bit limited in that regard. A couple of cases, this is an ovary. We've got these little bright spots, literally sort of almost ornamental around the outside of the ovary, look like little Christmas decorations around here. So this is, we think, is suspicious for superficial endo around the ovary. And on this side here, we've got a little pocket of fluid in the cul-de-sac, and you can see these tiny little projections outlined by the fluid. Superficial endometriosis, suspicious for superficial endometriosis in this patient. So the traditional routine pelvic ultrasound, which has been focused on the uterus and the ovaries, even when it's done really well, can miss many key endometriosis features. The 2016 IDA consensus protocol delivered an international stepwise approach for detailed evaluation of endometriosis, and now this has been incorporated into not only Australian but global best practice, which is pretty amazing. So everybody around the world is now using this stepwise 4-step technique to look for, map out, and describe endometriosis in the pelvis. I think it's pretty fantastic. The guidelines do make very specific comment about the importance of recognizing endometriosis in adolescence, which is new. And I just wanted to make a couple of comments about it. So when it comes to imaging in our young girls, and we are seeing so many adolescents come in for scans with their mums, which is amazing. We have a whole generation of endo warrior mums who have been to hell and back, and now they are bringing in their daughters because they do not want them to go through what they went through. So they are presenting earlier. They are presenting very early on in their menarche with symptoms, and they want them to be investigated earlier, which is fantastic. We need to keep a few things in mind. Firstly, the imaging findings may be very subtle. Early disease may, and I'm going to suggest will, not always be visible. The symptoms may not correlate directly with scan findings. And this is incredibly important. A normal scan does not exclude endometriosis. And therefore, this is why I go in and see, well, all of our patients, but particularly sit down with our young girls and with their mums and go through this in a fair bit of detail, because often we are limited to transabdominal scan in our adolescent patients, which is completely reasonable. And it's important to point out to them that we are limited if there is no overt Müllerian anomaly, no big congenital variation in the shape of the uterus, no big hematometra, no big dilated system full of blood, no big dilated cervix or vaginal canal. If there's no large ovarian mass, no big cyst, no endometrioma, then there may not be anything to find, anything large or overt to find. But it's important to rule those things out. So we are not only looking for findings for endometriosis, and we certainly have not ruled out endometriosis just because we did not find anything on this. We did not find endometriosis on the scan. We most certainly have not ruled it out. But what we have done is ruled out all those other things. We have determined that you have a normal shaped uterus. We've determined that the endometrium is uniform or not uniform. We've determined that the cervix has a normal appearance, that there are 2 ovaries, that you have multiple follicles. So we have established a very good baseline scan with which to compare down the track, and we have most certainly not ruled out endometriosis in this pelvis. And I think I have a very comprehensive conversation with these mums and their daughters at the time, so that they do not leave despairing that we have ruled out endometriosis and that we thought that they were making it up. It's very important, I think, to have that conversation. We also believe in autonomy at our practice. So there will be young girls who use tampons. They may not be sexually active, but they would like to try to have a transvaginal scan. We talk to them about it in detail, and we certainly have young girls who volunteer to have a transvaginal scan, and if they attempt it, if they find it to be acceptable, then we try with a transvaginal scan. So we certainly believe that girls should make that choice themselves. So let's talk a little bit about MRI as a modality for endometriosis. It is an extraordinary one, and it is something that we have used very effectively for imaging for MRI for many, many years now. I've certainly been doing it for over 20 years. We've only had this item number since November 2022. It was hard-fought and won, and it is still a little limited with respect to which patients qualify for this item number. Unfortunately, it is still limited to the pre-surgical patient, and is a specialist referral only. It is for the surgical planning of a patient with known or suspected deep endometriosis involving bowel, bladder, or ureters. So it is a little bit limited. Indication is still a bit limited at the moment, but we know that things can change, so keep that in mind. When we talk about MRI findings in endometriosis, again, let's talk about our 3 subtypes of endometriosis: superficial, ovarian, and deep disease. Similar to ultrasound, superficial endometriosis is difficult to see on any imaging, and that's no different for MRI. It is difficult to resolve those very, very small superficial deposits. We have one sequence where we can suggest that there may be some superficial disease. It's a T1 fat saturation sequence where we see these tiny little T1 hyperintensities. And in similar location, obviously the distribution is similar around the ovaries, in the cul-de-sac, in the dependent areas in the pelvis, and we can raise the possibility of superficial endometriosis on a scan, but it's hard to be definitive, the same way it's hard to be definitive on ultrasound. No such question mark when it comes to ovarian endometriomas, because they have a very telltale, very specific appearance on MRI. So they are thick-walled cystic structures. They contain these non-recent blood products of variable chronicity because they've been building up over years, collecting blood products over years. And while they're not considered to be deep endometriosis as such, they are markers for concomitant severe disease. So we talk about them being tip of the iceberg lesions. If we see an endometrioma, we know that there's endometriosis elsewhere in the pelvis. In fact, it usually means that there's extensive endometriosis elsewhere in the pelvis. The majority of endometriomas will be intra-ovarian pseudocysts, so not true cysts. They have started off at some point usually as a deposit on the outside of the ovary. Over time, as they continue to fill and build, they will become invaginated into the ovary itself. They're bilateral in about 50% of cases. And just from a descriptive terminology point of view, when they're less than 10 millimeters in size, we describe them as microendometriomas, greater than 10 millimeters in size, and they are endometriomas. They are T1 hyperintense. So just as a general rule of thumb, T1 is our functional series. This is just a crash course in MRI. T2 is our anatomical series. So T1 hyperintense means that they will be bright on T1. And then when we apply fat saturation, that means this gets rid of or makes dark everything else that fat basically. So that then they just become brighter and they stand out even more so. So we sort of say they light up like a Christmas tree. Here we go. So everything else is black and then they just look bright. So they have a very obvious telltale appearance. We talk about T2 shading, which is the T2 where they have this sort of graded variable appearance on T2 weta sequences, and that's usually due to the high concentrations of protein and the iron from repeated hemorrhage over a long period of time. And sometimes we see these little dark spots that float around in the periphery. Again, probably, we're not entirely sure what that is, but probably just some proteinaceous material. Kissing ovaries, sounds romantic. Not really. Unfortunately, the opposite is true. These are ovaries that have been pulled ruthlessly from their normal position where they've been sitting in the lateral ovarian adnexal position, ovarian foci, and they've been dragged, kicking and screaming, into the pouch of Douglas, often into the rectouterine space, and they've been forced to stare at each other forever, well, at least until the surgeon pulls them apart. And they're stuck to each other, not only to each other, but usually to the posterior serosal surface of the uterus as well. And this is usually indicative of quite severe disease. So when we describe or show evidence of kissing ovaries, it's not very romantic at all. It's in fact telling the surgeon that there's going to be quite complicated surgery involved. Hematosalpinges is actually a bit of a misnomer. So these dilated fallopian tubes are actually not filled with blood. They're in fact filled with dense proteinaceous inflammatory fluid. So they're actually hydrosalpinges filled with that sort of T1 hyperintense, dense proteinaceous fluid. So let's talk a little bit about deep endometriosis. And again, we spend a lot of our time on MRI the same way we spend a lot of our time on ultrasound looking for nodules of deep disease. And these deep nodules, again, nodules, as we said, like with ultrasound, they extend under the peritoneal surface. We used to talk about it being more than 5 millimeters was the histological definition. Solid lesions that are comprised of a combination of glandular, stromal, and fibrotic tissue. And we see them in the common areas, the same place that we were looking for them with ultrasound. Obviously, uterosacral ligaments, ovarian foci, posterior cul-de-sac, fallopian tubes, the bowel, the urinary tract, the small bowel. The implants or the plaques have a couple of different components on MRI. So if they've got active glandular components, they tend to be T1 hyperintense, so bright on T1, which means they've got bright bits in them. So that's the microendometriomas, hemorrhagic component, or they can be chronic stromal fibrotic. They look this sort of stellate appearance, which is more linear and stellate, and that means they're more hypointense or similar to muscle tissue, and that's when we see them best on T2. So a couple of examples. This is a lady who has terrible disease, poor thing, and it's in the anterior compartment. So when we're talking about the anterior compartment, probably know this already, but just to review, anterior compartment is everything in front of the uterus. Middle compartment is usually the uterus, cervix, vagina, ovaries, everything in the middle. Posterior compartment is everything behind that. So this lady has quite severe disease wedged in here between the uterus and the bladder. This is the vesicouterine pouch. So she's got this large amount of nodular looking plaque. When we look at it in the axial plane here, you can see there's a huge amount of disease here. And these are the ligaments going off on either side, round ligaments on either side. And you can see all of this disease wedged in here. So she's got quite severe disease. A bladder nodule eating into the bladder on this side. And this poor lady has a left ureter that's fighting its way down through the pelvis, but in fact is completely encased by this very stellate looking nodule that you can see, which is very fibrotic and stellate looking and is completely extrinsically compressed, that ureter on that side. Serosal plaques in the posterior compartment. This is a plaque that's attached itself to the posterior surface of the uterus. And you can see how this has pulled the uterus into this dog legs configuration that we were talking about before. So this uterus was at some point anteverted, but is pulled into retroflexion, and it's all because of this disease in the posterior compartment. And it's managed to span this space and attach itself to the bowel as well. And here it is in the axial plane, tracking out to involve the uterosacral ligaments bilaterally. And honestly, this is where I live now. I live here in this space, in this posterior compartment, spending a lot of time looking for bowel nodules, looking for bladder nodules, but most of the time looking to see to what degree this disease is involving the bowel of these poor girls, because this is going to directly affect the surgery that these girls will have. So is the bowel involved in a superficial way? Can the surgeon just shave it off themselves? Is the bowel more intricately involved, and to what degree is the bowel involved, over what distance, and at what level? Is the colorectal surgeon going to need to be involved? How much bowel will need to be removed? Because my greatest fear is that they will go to theatre. There's a bowel nodule that I have missed. They will go in, the surgeon will go in, have a look, see the bowel nodule, close her up, send her home, and need to rebook her for surgery with the colorectal surgeon. So she has not only had a wasted MRI, she's had 2 surgeries. So this is why I'm going to use every single tool at my disposal, be that rectal gel, be that vaginal gel, be that Buscopan, be that every single thing that I can use to get the best possible imaging, to make sure that we have done everything that we can to facilitate the best surgery, to make sure that she has it done right the first time, because this woman deserves the best surgery, every opportunity. She's suffered enough. So again, nodules, expanding the posterior vaginal fornix, and invading bowel here. And this is one that's very subtle, which is why the rectal gel here has been incredibly valuable to show us that this is actually a full mucosal, submucosal nodule. And again, everything that we can use, I'm staring at diagrams all day long. We're using everything that we can to try to document the involvement of the bowel, to what degree bowel is involved for these poor girls. So what is the role of MRI when it comes to endometriosis? It's twofold. Firstly, as a pre-surgical tool, as we said, and we've been doing this now for many years, but particularly over the last few years while we've had this very valuable item number, to visualize those laparoscopic blind spots, the rectouterine space, the retrocervical space, the uterosacral ligaments, the bladder, the bowel. It's a valuable tool in pre-surgical workup for patients who have known or suspected deep endometriosis, particularly when multi-specialty involvement may be necessary, when we may need to involve the urologist or the colorectal surgeon. But not only that, it's an invaluable tool for counseling patients prior to surgery. Now, I do a lot of ultrasound as well as MRI, but there is little else that you can say when you see a picture like this or a picture like this. You can take this image and you can send this to the surgeon, one picture, and someone can hold it up for them in theatre, and at a glance, this image makes complex endometriosis, distorted anatomy, instantly recognizable for that surgeon. So they can look at that and they know what they need to do. They know that they need to involve the colorectal surgeon just by looking at that picture. They know that they probably don't need to involve the urologist just by looking at that one picture. But not only that, they can take that image and they can sit down with the patient and they can say to her, this is why you have had dreadful bowel-related pain. This is why you have had these terrible symptoms over the year. They can validate her terrible symptoms with just these images, and they can explain to her, I'm going to need to sit down with my colleague, and we're going to plan out how we need to remove this bit of bowel. I'm going to need to consent you for this and this and this and this. It is so much more straightforward to counsel the patient about the surgery with MRI. Ultrasound is brilliant, but I think this is where MRI has the edge. A second role for MRI is definitely now as a valuable option, second-line imaging tool where transvaginal scan is inconclusive or unable to be performed, not only when patients are unwilling to have transvaginal ultrasound, when they're not sexually active, when they've got terrible crippling vaginismus, when they have been traumatized, but when symptoms persist despite transvaginal ultrasound and it hasn't yielded any results. The caveat to that, I think, is important to remember that very small superficial lesions and very small deposits of endometriosis will similarly not be detectable in MRI the same way that they may not be detectable on ultrasound. Let's keep that in mind. So we have had cases where girls have had a pristine transvaginal ultrasound, been sent for MRI, and have symptoms, but there may not be findings on MRI as well. It's easy to get despondent when there's nothing to find on the imaging, but clinically, if they have a good picture for endometriosis, we know that we may not be picking up everything with imaging, so we cannot rule out superficial disease despite the lack of findings on ultrasound or MRI. Keep that in mind. Standardized reporting is good for both modalities. It improves communication between the specialties. It gives a compartmentalized review of pelvic anatomy. Key strength in enhancing our diagnostic sensitivity. Structured reporting means that we're not going to overlook areas if we structure the way that we report it. It gives us greater clarity in the findings. It aids patient counselling. And I think it's good too for data collection for scientific purposes. So it's just a good way to report. This is basically the way that we're reporting both the MRI and the ultrasound now, compartment by compartment, anterior, middle, and posterior compartments. When we look at non-gynecological endometriosis, so this is endometriosis, these are endometriosis deposits that are extrapelvic or atypical. They can be really difficult to diagnose, and it's the catamenial or period-like nature of these symptoms that are going to suggest the diagnosis. And imaging here is really going to be fundamental to the evaluation. And there are many, many sites where we see this non-gynecological endometriosis, but I'm just going to talk about a couple of them. Probably the most common one that we see would be abdominal wall implants, so embedded in subcutaneous fat layer, near surgical scar sites, so commonly near cesarean scar or laparoscopic port sites, and they can be misdiagnosed as lipomas, hematomas, stitch granulomas, and we have been asked on several occasions to try to distinguish between a desmoid tumour and an endometriotic deposit. And we will reach for the ultrasound first because we can often see them. Patients will, particularly if they present in the first phase of their menstrual cycle, they can feel this, they can put their finger on them, they can pinpoint them quite easily. We're going to use a superficial or linear transducer, and they often will look like hypoechoic nodules or masses with an irregular contour. Sometimes they'll have little cystic areas in them. They don't have much in the way of blood flow. Sometimes little peripheral vessels will actually be normal tissue that's been displaced, and often they're amenable to needle biopsy. When we have a look with MRI, we can often see these little microendometriomas that we talked about before within the nodules themselves if they are nodules of endometriosis, extrapelvic endometriosis. And the benefit of MRI is that we can see to what degree the underlying tissues have been involved. Is there involvement of the underlying rectus muscle? And it gives us an idea of spatial contrast resolution. If there is a question still about a desmoid tumour, we can give contrast. The thoracic endometriosis syndrome is just the most horrific thing. Some of these poor girls who present with catamenial pneumothorax, imagine every period actually blowing a pneumothorax or coughing up blood. It's just unbelievable. And we have girls in this boat. It's just dreadful. Or having crippling right shoulder tip pain every time you have a period. So this is where MRI is actually incredibly helpful for looking for subdiaphragmatic, diaphragmatic, pericardial, or even pleural nodules in our patients with suspected thoracic or subdiaphragmatic endometriosis. And similarly, lumbosacral nerve roots, we have seen endometriosis wrapping around lumbosacral nerve roots before. It has an almost cancer-like ability to just encase nerve roots. One of the few occasions where we might actually use contrast to see if we can diagnose extrapelvic endo involvement of nerve roots. So, okay, this is all well and good, but let's come back to the here and now. So while comprehensive IDEA examinations are allowing detailed mapping of the disease, they also require additional expertise and much longer scanning times. We know this. And as a result of that, efforts are currently underway to upskill the sonography workforce across Australia and New Zealand as we speak, and not just with IMED, but with all imaging groups. However, this is understandably a gargantuan task, and it's going to take some time. Increasing referrals for suspected endometriosis and the introduction of the Medicare item number 55080, so that came out on November 1st, 2025, for the complex gynae ultrasound. means that we needed a structured operational approach to maintain diagnostic quality for our patients while preserving patient access. So we have tried to come up with a tiered approach, I guess, approach for this. And this is sort of what we've decided, what we're thinking of doing. So we've got the routine pelvic ultrasound, which is the original 55065 Medicare item. So this is your standard pelvic ultrasound, if you like. Typical booking time for this at IMED is about 30 minutes. Typical indications are, but not limited to, of course, patient with pelvic pain, abnormal uterine bleeding, maybe infertility, a general gynae assessment, query polyp, incidental pelvic symptoms. Then we have the next tier, which is an endometriosis screening ultrasound. So this is going to trigger a complex gynae scan Medicare item number, in some cases 55080. This will allow for a longer booking time, so more than 30 minutes. We're going to allow 40 minutes for this booking time. And typical indications here would be, but again, not limited to, the query endometriosis scan, query DIE, query adenomyosis, patient with dysmenorrhea, infertility with suspected endometriosis. Now, this examination represents an endometriosis screening ultrasound, and it's derived from the structured IDEA framework designed to identify those patients who may require specialist imaging or referral to a specialist. So we're trying to use this scan to screen for endometriosis. And then we've got our last here, which is the comprehensive DIE detection and mapping ultrasound, which of course will be a complex 55080. This is the 45 to 60 minute scan intended for detailed evaluation, mapping of DIE. Indications would be specialist referrals for endometriosis mapping, suspicious findings on a screening ultrasound that suggest endometriosis known, or those who actually have strongly suspected deep infiltrating endometriosis, or those who have endo and are going for preoperative planning. But I would also suggest maybe adolescent patients, anyone that you would like to have a specialist opinion, as in a specialist imaging opinion, would also qualify for comprehensive DI detection mapping ultrasound specialist referral. So what do I write on the form that's going to get my patient an endometriosis screening ultrasound? You write query endometriosis, query DIE, query adenomyosis. That is going to get your patient a complex ultrasound time allotment and item number at IMED. It's literally that simple. So if you would like them to have an endometriosis screening scan, then write the word endometriosis on the form. I know that sounds simple, but it really would help if that's what you wrote: query endometriosis, query DIE, query adenomyosis. That's a good start. In summary, I think a couple of things from today. I'm sorry, it's been a long talk, but I think things to take away: TV ultrasound is the preferred first modality of investigation for known or suspected endo. It's highly accurate for ovarian and deep pelvic disease. It offers real-time assessment. It delivers results for both diagnosis and for detailed mapping. Superficial endometriosis is still going to be often undetectable, but we're getting better at it. We're getting better at it with ultrasound. We're getting better at it with MRI. It's still going to be suspicious for in a lot of cases, but like everything with endometriosis, our learning curve is steep and we are making advancements in that area. MRI is extraordinary for pre-surgical workup in those patients who have known or suspected severe disease, and is essential for investigation of extrapelvic endometrial implants. But let's consider it also in cases where transvaginal scan is not feasible or deep endometriosis is suspected on screening transvaginal scan. Thank you very much for listening. I want to acknowledge my colleague, Dr. Stephen Sinnott, Dr. Yazdani for his help today, Luke Danaher, who helped put together our best practice guidelines for IMED, and to all of the radiographers and sonographers at IMED. Thank you very much for your attention.
Thank you very much, Dr. Sutton. We've got a few questions to go through. You just touched on this recently in your last few slides, but I thought we could just recap it for the audience. Someone has asked if they've got a young woman presenting with severe period pain, querying endometriosis, can you just confirm what do they need to put on the request form to make sure the correct scan is performed?
Okay, yes, good question. So I think if you have someone who is presenting, particularly as a first-line investigation, this is the sort of patient who I think is going to be qualifying for a screening ultrasound, screening endometriosis ultrasound. So I think it's really important. This is the sort of patient who will qualify for a complex 55080 ultrasound. So if you can write her history on there, but write the words query endometriosis, query DIE. Literally those are the important words to write on the form, and that will trigger and if she turns up then to a clinic, that will ensure that she then has the proper time allocated for her scan. So she will be booked for a 40-minute complex pelvic ultrasound scan, and that will mean that she actually has a proper screening endometriosis ultrasound. At this stage, there may be certain clinics that are not offering screening ultrasound scans. We're making sure that we have as many clinics as possible who'll be offering that type of scan, but the patient will be told at the time when she books it whether that scan is offered there or not. So, that we will make sure that she is at a clinic where that scan is offered.
Perfect, thank you. Someone was asking if you could just, in terms of MRI of the pelvis, can you just give a quick breakdown on the use of IV contrast and Buscopan, and which type of contrast agent provides the best diagnostic clarity?
Absolutely. I think it's interesting. So everyone does this a little bit differently. And certainly when it comes to endometriosis, MRI, our protocols are that we don't usually use IV contrast routinely in our patients with endometriosis. So we do use Buscopan in all of our pelvic MRI. And the reason we use Buscopan is because it calms the bowel. So we're looking at pelvic structures and we need them to be very still. Particularly as we're looking at areas between the rectum and the uterus, and it's very, very important that we have the bowel as still as possible because we're looking at sort of subtleties with respect to bowel wall. So for all of our patients who have pelvic MRI, particularly for our endometriosis patients, then we order Buscopan. For a lot of our patients, because they don't need intravenous contrast, then they don't necessarily have an IV cannula in. So for a lot of those patients, they actually have IM, intramuscular Buscopan, which works very well. Then we just make sure that they're not driving home on their own, all the rest. But intramuscular Buscopan works very effectively, so they don't actually need to have a cannula, which is good. All of the patients who have endometriosis MRI that is booked through and reported by SOGI, by myself and my colleagues, we will order rectal and vaginal gel. And it is something that unfortunately we're the only ones that do, nobody else does. And it's something that I feel quite strongly about because it shows, and something I've always done, because it shows the vaginal wall and it shows the bowel wall very clearly. And as I was saying during the talk, this is an area that we're looking at very carefully. This is an area that it's very important to try to determine whether there's involvement of the bowel. And we get one shot at this MRI. And if we don't identify it and there's any ambiguity about whether the bowel wall is involved, then having to try to get the patient back, trying to determine if that bowel is involved is very difficult down the track. So a lot of people don't give rectal gel because it takes extra time, because it means that the patient's in the unit for longer. Honestly, our patients don't care when it's explained to them properly, when when it's done properly, when it's done very carefully, when it's done with dignity. Our patients are very compliant and very understanding, and they are very accepting of the rectal gel. They just want the scan done properly. They just want the answers. So they don't have any issue with vaginal and rectal gel for the most part. Very few do. And if they don't want it, we don't give it to them. So they don't have IV contrast. They have Buscopan. They have rectal and vaginal gel. And honestly, as the years have gone by, a lot of the surgeons have actually requested that a lot of the other units use vaginal and rectal gel because it makes the pictures easier for them to see. And when they're standing in theatre using those pictures, trying to do their surgery, they find it easier to see with rectal gel as well. So it's interesting. There's been a bit of a turnaround and they've actually been requesting the gel from other units as well. So I don't know that any other units actually use it. A lot of the overseas units, weren't using it, now they're starting to use it again. So it just makes things a lot clearer. So no IV contrast as a rule. We only use it when patients had a hysterectomy because it makes the vaginal anatomy a lot clearer. When there's a concern about uterus, about nerve involvement, if there's some sort of other thing like fibroids, and if there's additional pathology that we need to have a look at. But if it's just an endometriosis scan, we don't use IV contrast routinely.
Perfect, thank you. Our next question is, how do you differentiate other solid ovarian tumours from endometriomas?
Yeah, that's a good question. And I guess that would, endometriomas have a very typical appearance. So we use a series of sequences on the MRI to distinguish between them. And often we can do that without contrast. Endometriomas have a very typical set of typical behaviors, if you like, with MRI. So the T1 and the T2 weighted sequences have very typical appearances of endometriomas that other tumours don't have. But if there's any question mark about something, then we will get the patient back and we'll give them contrast. So we look at pictures very carefully. If there's some questionable structure within the ovary that we don't like the look of, then we will always get patients back and we will do additional imaging to nut out that question. So we will never look at something and go, we don't know what that is, never mind. We will always get them back and we'll do additional imaging and we'll make sure that we answer that question. But endometriomas have such a typical appearance that there's very little else that looks like it. So when we see them, we pretty much know what they are.
Thank you very much. We actually have quite a lot of questions coming through just regarding the use of MRI referred by a GP, especially when ultrasound has not been conclusive, or perhaps the patient themselves is requesting an MRI. So bearing in mind that they are, that the item number is a specialist referral only, can GPs actually refer for a private or a non-rebatable MRI?
They certainly can. They most certainly can. And we get a lot of referrals from GPs for MRI and a lot of, and I protocol those every single day, and they most certainly can. And that sort of is what we were saying, I guess, in that second arm of the indications for MRIs. So when there are persistent symptoms, when transvaginal scan has been inconclusive, when a patient can't have transvaginal scan, or they've been, I guess, has not yielded any results, and we've certainly had patients requesting, or GPs requesting MRI. And there's certainly a place for that, absolutely. I mean, obviously there is no rebate for it, so patients will be out of pocket. That's the only downfall. But it is certainly something to consider. And yes, there is certainly a place for MRI referral in that regard. I guess the thing to consider is we may not find signs of deep endometriosis, but we're going to look really hard for it. We're going to look just as hard as we are for someone who's got known endometriosis. And we're going to look for any other cause for pain. So, even if we do an endometriosis protocol, we're going to scour that pelvis and look as hard as we can for any cause for pelvic pain. And we find things all the time. We find, ovarian cysts, we find fibroids, we find all kinds of things in there. So there's lots of, there's lots of good reasons to think about MRI as a modality subsequent to a non-yielding transvaginal ultrasound.
Thank you. Another question here is just asking, is there any specific scan that we use to investigate prolapse?
That is a good question, and I don't have a lot to do with the pelvic floor imaging, believe it or not. There are some dynamic pelvic floor studies that IMED is doing at Chermside, and there are one of our specialists over at Chermside is actually doing some really good dynamic pelvic floor studies. So there's some really good work that we can do with dynamic pelvic floor work. So we actually do like cine loops while the patient is in the magnet. We actually do some real-time studies. There's also some really good ultrasound that we can do for pelvic floor that's just as good. So there's lots of dynamic pelvic floor work that we can do with both types of imaging, and there's a lot of that's been done at Chermside. So I don't have much to do with it, but yes is the answer.
Thank you very much. We also had a couple of questions which I can probably answer just around availability of these sorts of scans and costing. As you mentioned, our clinics across Australia are very well equipped to manage these sorts of queries. So contact your local clinic. If they don't offer the scan there, they will be very well equipped to help you find a clinic nearby that does offer that scan. Would you agree, Bridget?
Yeah, they are. I mean, it is hard. I think there has been such, as in, don't get despondent if there's a bit of a waiting list. There has been such a wave of requests for endometriosis imaging nationwide. So that's specialists, that's GPs. There's just been an enormous groundswell of endometriosis imaging requests. So there are some maybe a little bit of a delay in some clinics to get a scan, but it's certainly, we're working through it, and we are definitely getting a lot of scanning done. So, we are definitely doing a lot of pelvic scanning, be they ultrasounds or MRIs. So yeah, be persistent. We will get your scan done.
Fantastic. Thank you very much. I think I will wrap up the evening there. I just wanted to remind everyone online to just check the handouts tab for that evaluation form. Your evaluation is extremely important in helping us direct our education to make sure it's relevant and helpful for you guys. I'd like to thank Dr. Bridget Sutton for the amazing presentation. It's very needed and very timely. And I'd like to thank everyone for joining us, and we'll see you next time.